Is my screen visible?
Yes.
So welcome you all to today's session. So the first session will be on HPV positivity post hysterectomy, and I would like to invite the chairpersons for this session. Our first chairperson is Dr. Leela Digumarti. She is an gynecological oncologist practicing at Saint Teresa Hospitals and Ashwin's Hospital, Hyderabad. We also have with us Dr. Smita Joshi. She is a senior scientist at Jahangir Clinical Development Center, Ruby Hall Clinic, Pune, India. And we have Dr. Geetanjali Amin. She is a medical officer in preventive oncology department at ACTREC and Tata Memorial Center, Navi Mumbai. The speaker for today's session is Dr. Bhagyalakshmi Nayak. She is professor, Department of Gynecological Oncology at AHPGIC Cuttack. She is also honorary secretary at AJOI and chairperson Oncology Committee FOXI from 2018 to 20. I would invite Dr. Bhagyalakshmi Nayak to take over and present her talk.
Hello, ma'am. Are you there? Bhagyalakshmi, ma'am. I will just try to call her. Madam is joining. So till then, we can discuss about today's topic before madam's starts her talk or her views on this testing. Many times what happens, one recent case with me has happened. The patient had come with severe abdominal pain and she had big fibroid about 12 to 14 weeks size, and she was 46 years old. She was not in screened, means no pap smear or no HPV was done, and she was in severe pain. So the sonography showed some degeneration in the fibroid. It was a big fibroid, so I had to operate her immediately. But before that, I took her HPV and cytology also. But before the reports were with me, I had to operate her. And unfortunately, after surgery, she was HPV positive. I had done her hysterectomy, and it's just 6 months back only. And now I'm worried whether she comes for follow-up or not. I have told her everything, because what happens, they say HPV positive means hysterectomy is in their mind. So just a second, madam is calling.
Dr. Bhagyalakshmi has joined. There's some heavy rain today here. Actually, the network is not very good. So still I'm trying. Yeah, we can go ahead.
Yes, ma'am.
Sorry for joining late.
Ma'am, you can share your screen.
Yeah.
We have finished your introduction also, ma'am.
Oh, done. My God, I'm so sorry I joined late.
No, it's okay. It's okay. No problem.
Good evening, Bhagyalakshmi, madam.
Good evening, ma'am.
Good evening,
Is
madam.
my slide visible?
Yes, ma'am. Yeah.
Okay. So can we start?
Yes, ma'am. Please.
So I think extremely sorry for joining late. So sorry, Dr. Aruna and all, for keeping all of you waiting. But this was for some technical little problem I had. So I think thankful to Dr. Bharti for giving me this very interesting but a very clinical subject about HPV positivity post hysterectomy. So what we should know about how to screen women after hysterectomy, whether we should do HPV positive HPV test or not to do a positive HPV test. So I bring you greetings from the land of Lord Jagannath. So I think this one is the largest population-based study of vaginal human papillomavirus infection in hysterectomized women. So this is a landmark study actually, which was done in Costa Rica under the leadership of Mark Schiffman. I think all of you know that he is a pioneer in cervical cancer prevention studies. So this was the first population-based study of HPV prevalence in hysterectomized women. Among 6,657 women of total, 569 hysterectomized women and 6,098 non-hysterectomized women. It was conducted at Costa Rica and conduct of study of vaginal infection without confounding influence of cervical tissue. So here we could see that there was actually in fact no difference between the prevalence of high-risk HPV among hysterectomized and non-hysterectomized women without history of CIN2. So when they have a history of CIN2, it is different. So when they do not have any history of CIN2, the risk of having a HPV infection is the same whether she had a hysterectomy, whether she did not have a hysterectomy. So the risk of prevalence of HPV is quite the same. So here you can see that there is an increased prevalence of any type of HPV subtypes among hysterectomized women. However, there is no difference exists between the cancer-associated HPV subtypes. So when we can come to this, whether it is the cancer-associated ones are different, but there is no difference between the cancer-associated HPV subtypes in hysterectomized or the non-hysterectomized women. Yes. And so here again, we can see that there is increased prevalence of non-cancer associated increased prevalence of non-cancer associated type of HPV subtypes among hysterectomized women, unlikely to result, but the very important thing is that they hardly result in any cytological abnormalities, though the prevalence is high even after hysterectomy. I don't know why my slides are not moving. Yeah. So the presence of vaginal HPV DNA, cancer associated in hysterectomized
Just
women.
a second, madam. I request to unmute somebody's mute. I mean unmute because somebody is talking in between. That is causing some disturbance. Yeah. Okay, madam. Continue.
Am I audible? Hello?
Yes, madam. You are audible. You are audible.
Okay. So the presence of vaginal HPV DNA in hysterectomized women and of cervical HPV DNA in non-hysterectomized women was related to a higher lifetime number of sex partners, a result suggesting that these HPV infections were sexually transmitted. So I think they actually did not have any effect whether she was hysterectomized or non-hysterectomized, because it was thought that it was dependent on the number of sexual partners that the woman had. And non-cancer associated HPV had higher in older substrata and increased with the number of sexual partners. And prevalence increased with duration from hysterectomy. So as the duration between hysterectomy increase and the HPV testing time, so the increase in the frequency of having these HPV infections. So the whole context was that husband having multiple sexual partners, but then it cannot be inferred as the cause of increase in HPV prevalence, even non-cancer types in old age. The reason for increased prevalence might be benign persistence for extended periods of time and can be considered as some commensal infections. Trophism of non-cancer subtypes for vaginal mucosa. But the very important thing is that the hysterectomized women were more likely to be positive for types 58, 61, 70, 71, 72, and 85, and the composite. So there were sometimes groups of HPV which were positive, like 2, 13, 34, 42 to 44, 57, 62. Combinations were also positive in hysterectomized as well as non-hysterectomized women. The prevalence of non-cancer associated HPV types in older women, especially the hysterectomized one, and in postmenopausal non-hysterectomized women for whom the squamocolumnar junction had migrated into the endocervix were similar. Higher non-cancer HPV detected in self-reported sample in menopausal women, similar in occurrence of cytological abnormality among hysterectomized women and non-hysterectomized women. Though the prevalence of HPV was thought to be more in women post-laparoscopic hysterectomy, but we don't have any scientific evidence which has been found for the same. So to this date, HPV prevalence by age by risk group in hysterectomized women in other population has not been reported. More studies among variety of populations are required to resolve questions about the vaginal HPV infection in hysterectomized women. So this is all about epidemiology. So after hysterectomy also, the HPV virus can persist in the vaginal epithelium, and this is however more if she has had a hysterectomy for a high grade lesion. So HPV testing post hysterectomy. So whom should we do? So this is actually from again the same study. Women without uterus have a similar prevalence of high risk HPV. Risk of HPV induced cancer is minimal. So even if they harbor the high risk HPV, the risk of HPV induced cancer is minimal, and hence they are unlikely to benefit from routine HPV testing. So it is not routinely recommended to do a HPV testing in women post hysterectomy where they never had a evidence of any high grade lesion in the cervix. However, there are definite indications to do HPV testing in women who had undergone a hysterectomy. Who are they? Women who had a hysterectomy for high-grade cervical lesions or cancer. So they need to have a HPV testing even after the procedure has been completed, because there is a risk of recurrence of the disease. The risk of vaginal cancer still remains elevated even after the surgery has been done. The vault incidence of vault cancer also is high in women who have had a surgery for high grade lesions. So then, and for all of us in clinical practice, I think if a woman has come to you post hysterectomy with some symptoms of watery discharge, white discharge, or maybe soreness of the vagina, I think it is very, very pertinent to have a look at the vagina, because sometimes we actually think that since the hysterectomy is done, cervix has been removed, so there is no fear of cancer, but that is a myth. So we need to look at the vagina, we need to look at the ward, and if she is complaining persistent watery discharge, I think there is no harm in doing a HPV testing if she had never had any kind of screening in the past. So then how do you do this HPV testing? We usually collect a specimen from the vaginal vault, and if she had a definite indication, it has to be done every 12 months and annually thereafter, and mostly continued up to 10 years, or at least till negative on 2 consecutive occasions. So there is a definite indication of doing HPV testing when it is necessary. So what are the clinical presentations that HPV positivity may present to us as post hysterectomy? It may be a simple positivity, but a positive for HPV, if she is positive for high risk HPV, they may manifest as vaginal intraepithelial neoplasia. So 1 to 7% patients undergoing hysterectomy due to CIN or cervical cancer may develop vaginal intraepithelial neoplasia in a 2-year period. So we have to be very vigilant about these women. Usually associated with persistence of high-risk HPV subtypes, post-treatment of high-grade pre-invasive lesions, HSIL or CIN3, and most commonly pathogenic lesions are associated with HPV-16 persistence in post-hysterectomy patients. So there are many case reports which have shown that post-hysterectomy vaginal cuff cancer is secondary to HPV infection and CIN. And I think me working at a cancer institute have come across many vault cancers which have happened after hysterectomies. Because I think in India, most of the time when we do a hysterectomy for a fibroid, or maybe we do it for a prolapse, I think it should be a guideline that we do some kind of screening for the cervical cancer. So for all my audience, I think whenever we are doing a hysterectomy for any benign cause, even if the cervix looks healthy, it's good to do some kind of screening for the presence of CIN or HPV testing, because we never know, and they would never show up in the histopathology specimen, but then after 5 years, after 10 years, they would come back with some kind of lesion in the vault or the vagina. So how is HPV managed after a hysterectomy? HPV management after a hysterectomy varies depending upon many things, whether or not the cervix has been taken out, whether it's a subtotal hysterectomy or a total hysterectomy, what is the type of HPV that has come out in your result, and the patient's personal medical history, because we need to take a personal medical history, whether she's immunocompromised or not, or any other steroids or whatever about her HIV status, all those things also come into play. So even when there is no cervix, the high risk HPV can still be a threat to the vulva and vagina. Though the incidence of cancer in vulva and vagina are less, though the cervical cancer is high, but the presence of HPV positivity after hysterectomy has a threat of causing a vaginal cancer or a vulval cancer. So that is why ongoing care and follow-up are still necessary. So then when you have a positivity HPV report, it is mandatory for us to do a colposcopy. But I think we'll all agree that doing a colposcopy after a hysterectomy is very, very technically challenging. But then it needs to be done. It is a skill which has to be learned. And I think senior colposcopists actually can do it better. So as you start doing, it will it is difficult because actually the vault becomes crumpled up. The lesions may be hidden inside the crypts. So we need to be very vigilant, very careful in doing a colposcopy at the in a hysterectomized woman. So here you can see that it was a high grade vaginal intraepithelial neoplasia in an HPV positive woman, 62 years old, in which the hysterectomy was done 20 months back for a CIN3. So here you can see that colposcopy examination of the vaginal apex after hysterectomy. So there are vaginal dimples which are difficult to inspect and biopsy. High-grade intraepithelial lesion extending into vaginal dimples is actually very, very difficult to pick up and identify them. And here in the third picture, you can see that's a obvious acetovite lesion, and you can see there are elevated ones and looks mostly like a high-grade lesion. And colposcopy directed biopsy should be done in these cases. So though technically challenging, but if you have HPV positivity after hysterectomy, colposcopy needs to be done, or we can call it as a vaginoscopy. So here again a vaginal carcinoma which has happened in HPV 16 positive 62-year-old woman 25 months after undergoing hysterectomy for a uterine fibroid. So I always tell that a fibroid doesn't tell you that I don't have a CIN, or the fibroid doesn't tell you that I don't have a HPV. So I think whenever we are doing a hysterectomy for a fibroid, it is mandatory that we should always screen for any CIN lesion of the cervix as well. So this is again a paper which shows that vaginal intraepithelial neoplasia after hysterectomy is strongly associated with persistent high-risk HPV infection. This study showed that there is a small risk of VAIN in women who have undergone hysterectomy due to benign uterine disease and with persistent HPV infection. But then it agrees that there is a subtle risk and we should not miss this. Persistent HPV infection can progress undetected to vaginal cancer as there is no follow-up program for these women. And this suggests that vaginal cytology follow-up may be warranted for all post-hysterectomy patients, but we don't have any consensus in the literature for that, but there is a definite subtle risk for that. So if a woman comes to you with symptoms, at least we should screen her, look at her, do all the tests that should be done in spite of her not having a hysterectomy. And that's a myth that if she has a hysterectomy, we should not screen her, there is no risk of cancer at all. So how do we treat them? So laser vaporization is one of the treatment modalities. This appears not to be effective in eliminating HPV infection. HPV infection persisted in many patients, around 61 to 89% in spite of the treatment. And in a study by Tanyo et al., HPV clearance is significantly higher in the imiquimod arm. I think imiquimod is a better treatment modality than in the laser arm or in the expected management arm. So imiquimod is a better modality, is a non-invasive method, but then we need a little patience that to take little time. But then that's an immunomodulator which can be used safely. So this is again a study by Brian et al. Which confirmed detection of 96% HPV in patient diagnosed with VAIN. So when you have a VAIN, I think that is the main important cause where HPV is the important association. Risk exists for women having undergone hysterectomy due to benign lesions with persistence of HPV infection, which may have been undetected initially, as these women are not asked for follow-up. However, routine vaginal cytology follow-up in post-hysterectomy patients is not backed by available evidence. We all know that. Only patients having CIN, cervical cancer managed surgically, are followed up routinely via cervical smear or HPV DNA. However, ASCCP recommends post-hysterectomy for CIN3 lesions, vaginal co-testing every 6 months for at least 2 years, then annually for at least 10 years. So how is HPV managed after hysterectomy? HPV management after hysterectomy, so this slide has been repeated. So sometimes we may need a surgical maneuver in the form of upper vaginectomy, which considered the treatment of choice for high-grade lesions, and in hysterectomized women for cervical cancer also. Surgical excision actually particularly indicated in patients in whom infiltration cannot be excluded. So we cannot use imiquimod mode in those cases if there is a suspicion that it could be invasive lesions. And when we do a surgery, we are confident that the margins are evaluated properly, and we are sure whether the margin is involved or not involved, which we actually cannot do if we are doing in some kind of vaporization techniques. However, carbon dioxide laser vaporization for sites other than the apex in multifocal lesions in sexually active young women can be done, and the prerequisite of should always be exclusion of occult invasive disease. So in case of multifocal lesions or lesions at the lower third of the vagina, upper vaginectomy can be combined with laser excision. So that this again we can do if there is extensive lesion, we can do upper vaginectomy along with the laser excision. Regardless of treatment modality, patients with high-grade VAIN are at high risk of recurrence in spite of any kind of treatment. To avoid the formation of vaginal crypts, so this is for people who actually are following hysterectomies, especially vaginal hysterectomy, which has become more common now. So to avoid these crypts, which prevents colposcopic vision and biopsy of the possible lesions, some people recommend not suturing both ends of the vaginal apex to the cardinal ligaments, so that it becomes pulled up and puckered and it becomes difficult for us to assess the vault. So then comes the role of, is there a role of post-operative HPV vaccination? Then definitely it can be considered or should be considered, in fact, for women post-hysterectomy for CIN2, because it definitely reduces the rates of recurrence. Sand et al. Demonstrated women vaccinated before surgery have a lower absolute risk of developing HSILs compared to women vaccinated post-surgery and unvaccinated women. Sufficient neutralizing anti-HPV antibodies to prevent reinfection of the basal layer cells are very, very important. So the European Society of Gynecological Oncology, ESGO, International Society, ISSVD, the European College for the Study of Vulval Disease, and the European Federation of Colposcopy consensus statement for the management of vaginal intraepithelial neoplasia. So this is a step forward of HPV positivity in post-hysterectomy. So mostly they would manifest as vaginal intraepithelial neoplasia. So we had 5-fluorouracil, which can be used as a promising agent, but availability is a problem. So then imiquimod is a good drug. 5% cream, 0.25 gram once a week for 3 weeks appeared to be an effective and well-tolerated treatment for low-grade VIN. However, surgical excision may be used, and very advanced cases, sometimes in severe grades of VIN, brachytherapy may also be used. So these are the guidelines from the ESGO, ISSVD altogether. So yet in a retrospective study by Yu et al., they concluded that VAIN grade 2, 3 and VAIN associated with CIN or cervical cancer are more likely to recur and progress to invasive disease, and age over 50, only independent risk factor for recurrence of VAIN. So higher the age, higher the risk of recurrence of VAIN, and post-hysterectomy with prior diagnosis of VAIN, also there is a risk of recurrence is also very high. So this is again a study of cervicovaginal HPV infection before and after hysterectomy, evidence of different tissue tropisms for oncogenic and non-oncogenic HPV types in a cohort of HIV positive and HIV negative women. So they showed that oncogenic type specific analysis of HPV post-hysterectomy, this was a population-based study. This showed that HPV DNA was commonly detected after hysterectomy, suggesting that the vaginal epithelium is a common site of HPV infection. Vaginal HPV prevalence was significantly greater in HIV positive than in HIV negative women, and positively associated with HIV-related immunosuppression. host immunity plays an important role in control of vaginal HPV. But then at this point, I should again remind all of you that the vaginal microbiome is a very, very important factor which plays in the persistence of HPV persistence. So women who have recurrent vaginitis where the lactobacillus and where the vaginal microbiome is disturbed, there is a chance, and the microbiome is now coming up in a big way, which actually decides many things about our life, and so is the persistence of HPV infection. And hysterectomy was associated with significant reduction in oncogenic but non-oncogenic HPV prevalence, but not non-oncogenic HPV prevalence. Tropism of non-oncogenic HPV for vaginal epithelium and oncogenic types having tropism for cervical epithelium. So this was what they inferred, that the oncogenic ones had a tropism for cervical epithelium and the non-oncogenic HPV had a tropism for the vaginal epithelium. And the increase in time from hysterectomy, the prevalence of non-oncogenic HPV increases as the time lapse increases between hysterectomy. However, the reasons for all this is not clear. So I think I have come to an abrupt ending though, but then I think we need to understand that post hysterectomy HPV screening is an important thing that we all should remember, because I think we are not, most of us are, we think that HPV testing, we are not, what is that? We don't have access to HPV screening, but at least for women who have had a hysterectomy for CIN or any high grade lesion need to be screened. And for women who have already had a hysterectomy for a benign lesion, is symptomatic, comes to you with watery discharge or any other complaint, should be screened. So that is very, very important. But then we have a lot of studies which have shown that with age, even after hysterectomy, the rates of HPV persistence also may be there, and the risk of vulval cancer, vaginal cancer, and wart cancer should not be neglected. So thank you very much, Bharti, for giving me this very, I think it was a little complicated topic, but I tried to do little justice for that. Thank you very much.
And that's why it was given to you, madam, as the topic was complicated.
So thank you, Bhagyalakshmi ma'am. Now I would like to invite the chairpersons, Dr. Leela Digumurthy, then Dr. Geetanjali, and Dr. Smita Joshi to give their expert comments and to share their experiences regarding this subject.
Yeah, thank you very much, Dr. Tanvi, and thank you, Bhagyalakshmi Madam. You have really made it the tough topic very clear to all of us, especially the last two sentences, what you have said, like women who are already treated for CIN, especially post-hysterectomy, have to be followed up with HPV, that's definite. And of course,
I
most
think
of us
we
are...
didn't add up, Dr. Leela, that even if it's not about hysterectomy, even if they had a cone or a lead,
Yes.
so those women also need to be followed up in a similar fashion.
Yes, so that is all of us, or most of us are doing it. But coming to the post-hysterectomy done for benign indications, what I personally feel are, actually you already mentioned, I think before subjecting them to hysterectomy, I think it's better we evaluate the cervix, do the HPV, and make sure that they don't harbor HPV in their cervix and the vagina. Because if we detect it later, we always get confused. Even the patient gets confused that, okay, I had hysterectomy, how can I get HPV? So many doubts they will have. So I think, as you have rightly said, this evaluation has to be done before doing hysterectomy, whatever may be the indication, benign. And I think in the old T-Lende, we all read that doing a cervical screening and taking an endometrial biopsy are mandatory before doing a hysterectomy. So that is the dictum most, I mean, that is what we were all taught. So you have nicely explained. And you were mentioning about non-oncogenic types. That means they are not in that 14 high-risk types, madam, or they're totally different types, I understand. Or there are other high-risk types?
They're non-oncogenic.
Non-oncogenic types.
Yes. So they could cause those warts and all those lesions.
Yes. Yeah. And of course, as you have said rightly, of late, I have seen very recently 2 women who had CIN3 and who had hysterectomies, lap hysterectomies for CIN3, coming back with vaginal intraepithelial neoplasias and other things. As you have rightly said, the colposcopy is challenging, but I am also learning doing colposcopy, and I could really see visible lesions and other things, madam. So very well, nicely explained. So I'll request the other chairpersons to share their
And
comments.
there is some, I think, divided opinion about increasing risk of recurrence after doing a lap surgery for these diseases. So I think it was a little controversial, so I have not put it in my slides. But there are some evidence coming up that even after lap surgery, the recurrence rates are a little higher.
Yes, madam. Actually, I've done the literature search because these two patients were referred to me following CIN3 hysterectomy done elsewhere. So even I was searching, but my numbers are only 2. So I couldn't really say anything about it, but that's just my little experience. Yeah. Thank you very much. Thank you for the opportunity.
Thank you.
Thank you.
Can I add something? One line, Bhagya? Dr.
Yes,
Bhagya?
yes. Welcome.
Bhagya, as usual, it was a really enlightening talk that nothing much to say. Actually, you said non-oncogenic means in the extended genotyping, we do see these non-oncogenic also has been reported to be giving rise to the cervical cancer also. Whether we have to be alert about those 42 and some of the phenotypes are recognized now. Whether that is the one intention, like we'll have to be looking for these extended genotyping phenotypes also before. And there is a trend, once hysterectomy done, if they come for a health checkup, anything like she may be 48 or 50, there is a trend in some of our doctors not to do any examination or any smear at all. Oh, she is a hysterectomized. Nobody wants to know what for she was hysterectomized also, because many may not have the prior report with them, any of this one. I think this trend is to be changed now, the way it is going on with all these vaginal neoplasia, everything. I just wanted more highlights.
Yes.
Yeah,
So with the
okay.
increasing hysterectomies now hysterectomy is available through that card. So
Yes.
thank God we have so many unindicated hysterectomies. So we'll now see more and more of the CA vaginas and CA vulvas. So,
Correct.
but thank God for that card, there is a test, at least you should needs a pap smear. So without a pap smear, you cannot do that hysterectomy. But then I'm sorry to say that people have now started making fake reports, so that they
Yes.
just have to upload and then do the hysterectomy.
Correct.
So they are doing hysterectomy for abnormal pap smears, madam. So that is a very bad thing.
Yes.
So
Yes.
thank you, Parimala, madam. So next
Thank you.
chairperson,
Thank you.
please, your comments.
Yeah.
Gitanjali, ma'am.
Please unmute, Gita.
Thank you, Bharti, for giving me the opportunity. Very well explained, Dr. Bhagya. It is a very tough topic. So I would say, as you repeatedly said, all women who are going for hysterectomy should have one pap smear and hysterectomy. And hysterectomized patients, when they come for the checkup, routinely at least do a per vaginal examinations, do a per speculum examination, whether the cervix is there or no, and make sure, and there are no lesions, and one pap smear or HPV has to be done, even though patient may not say, but we have to do the wall smear. That is there. As you said, the prevalence of HPV is common, hysterectomized and non-hysterectomized patients, and it is more so in the CIN positive or CA patients. They may become HPV negative, but they are at high risk of developing HPV after the age of 5 to 10 years. So follow-up of these patients post-hysterectomized HPV negative is also very important, because recurrence, reinfection of the HPV occurs after the age of 5 to 10 years, after a period of 5 to 10 years. So I had one case in the initial practice of mine, one who had a hysterectomy for 5 years back and referred for a discharge. In the elderly lady, 65 plus. But vaginally nothing was there. Pap smear was negative and HPV was negative. HPV I had not done. Colposcopy I did. I could see a lesion. I took a biopsy and it had come as VIN. But see, persistent where this thing, pruritus also can give rise to these vaginal intraepithelial in a post-hysterectomized patients. So follow-up of this hysterectomized patient is very important, and role of HPV is emerging. Though we were used to the wall smear, we have to make a habit of doing a vaginal HPV testing. Thank you.
Yeah, thank you, Gitanjali, ma'am. Dr. Smita Joshi, ma'am, please.
Yeah, thank you, Dr. Bhagya. It was a excellent talk, and thank you, Dr. Bharti, for giving me this opportunity. So I think the previous chairpersons have already said whatever was to be said. So the take-home message is to continue to screen women post hysterectomy when they've had a hysterectomy for a high-grade disease, particularly, and even though the hysterectomy was done for a non-CIN category, but but she was HPV positive. I think we should continue to screen them as well as we continue to screen those with a high-grade lesion. So this screening should continue at least for 20 years because these women remain at an elevated risk of high-grade vaginal lesions for the next 20 years. Thank you so much.
Thank you, Dr. Smita Joshi. So with this, we have come to an end to the first session, and we'll go with the second session now. So now we have a panel discussion on vaginal intraepithelial neoplasia and vulval intraepithelial neoplasia. The moderator for the panel is Dr. Bharti Abhyankar. Dr. Bharti Abhyankar is the Vice President of AMOGS from 2024 to 2026 and Executive Member of...
Tanvi, sorry, we have a short of time, so make it very short.
Yes. So she was the organizing chairperson of ISCCP Con 2025. Over
That's
to you.
all. Thank you. Next, you're going to introduce or should I start?
Ma'am, you can start now.
Now I should share my screen, no?
Yes.
Okay. So today's topic have been chosen very nicely because in every day we come across many women who many are our gynec patients. And just a second, I will make it a... So the topic chosen is very clinical topic, and for that I have expert of panelists with me, Dr. Sandeep Fadke. He's a famous colposcopist from Akola, and he has received the best paper award in recent ISCCP Con at Kolhapur from consultant category. My next panelist is Dr. Madhuri Gawande. She is working as a consultant at St. Tukdoji Cancer Hospital, Nagpur, as well as she's working in a NKP Salve hospital at Nagpur, and she's working very on preventive as well as actually she's in a cancer center. So she has a lot of experience and a lot of work. And one case is she's going to present of her own. The next panelist is Dr. Veena Radgaonkar Joshi. She's working as a consultant gynecologist at Dinanath Mangeshkar Hospital, and she has organized the first ISCCP conference at Tata Cancer in 2013. And very important is she has received an award for her short film Griva on cervical cancer. Griva is what we call in Marathi, that word is Marathi. So she has received the award and the film is very good. Everybody must see that. And today's our MOC, Dr. Tanvi Kulkarni. She is a pathologist. She's a very enthusiastic person. She has done her MD from Tata Memorial Hospital, Mumbai, and that's why she has a lot of experience, extensive experience in cytology as well as various immunohistochemistry and everything. At present, she is consultant at Jeevan Laboratory, Kolhapur, and she's a very active ISCCP member also. So, as I said, we come across many complaints in our OPD, and these complaints are very typically described by all the patients like vulval burning, stinging, soreness, irritation, feeling as if something is being cut with a knife. They describe it as a stabbing pain, sticking, and most important complaint is an itching, inflammation, and then there is a pain. So vulvodynia, usually it is vulval discomfort. Most often it is described as a burning pain occurring in the absence of any relevant visible finding or any specific neurological disorder. So there many times there is no difference in symptoms between vulvar dermatosis and vulvodynia, and that's why there is a concept of a three-ring vulvoscopy that we're going to see in these cases what exactly it is. We know that there are vulval lesions can be benign lesions of the vulva, which includes epithelial conditions, benign neoplastic disorders, and dermatological disorders. Then we have VIN, that is vulval intraepithelial neoplasia, characterized by abnormal cell growth in squamous epithelium of the vulva. Usually it is graded as low and high. We have vulval cancer, which is very rare. The incidence is less than 5%. 90% are squamous, and very bad thing, the age is decreasing from 50 to 39. There are causes of this VIN, mainly HPV infections by 16 and 18 type. Then HSV infection, lichen planus, lichen sclerosis. Immunocompromised women are very much prone for these infections. If there is a history of other intraepithelial lesion, just now we have heard from Madam very nicely, if the lady is having a CIN3 or she has been having cervical lesions, then definitely she is prone for developing these VIN lesions also. If she's a smoker and she's more than 50 years of age, she's vulnerable to develop the VIN. So again, the epithelial conditions are lichen simplex, lichen sclerosis, and lichen planus. We know the difference. Usually these VIN lesions, they are differentiated as U-win and D-win, popularly called as. U-win means usual type and D-win is a differentiated type. So U-win is usually seen in younger women and is associated with HPV infection, but the invasive potential is 9% and it shares same risk factors as that of CIN, and usually it is multifocal. Whereas the D-win characterized mainly seen in older women, it's not associated with HPV. It tends to be solitary, and there is 5 times chance to progress to malignancy. It's related to chronic inflammatory conditions or P53 gene mutations. Initially, this was the classification, and we have seen that this is U-win, which is again maybe warty bacilloid mixed type. D-win usually seen in older women and not commonly seen as an oncogenic infection. There are unclassified variety of WIN, which is rare, and pagetoid disease is included in unclassified variety. So ISSVD has given right from 86 to 2015 the latest classification as WIN1. Usually it is LCIL, WIN2 and WIN3. All these types, warty, bacilloid, or mixed type, they are HCIL, and there is WIN differentiated type, which is also included by ISVDD. So coming to our panel discussion, this is an interesting case again, emphasizing the point that usually these VIN lesions may be associated with SIN lesions. So this is my patient, 54 years old, G2, P2, L2, still menstruating regularly in spite of her age. She came with complaints of pain and burning at vulva with severe itching for last 2 years. She also had white discharge per vagina, which was not foul smelling. She is a case of diabetes, well controlled. Her HbA1c was around 6, and she has consulted dermatologist and was treated for same complaints. She was treated at many big institutes nearby. Her only LBC was done. It was ascus type. HPV was not done. So she had come mainly for pain, burning, and some kind of menorrhagia. So my first question is to Dr. Veena. How will you proceed to diagnose and what tests would you like to advise for this patient?
Yes, thank you, Dr. Bharati, for giving me an opportunity to participate in this webinar. The question you ask is how will you proceed to diagnose? This patient is having various symptoms like pain and burning on the vulva, and there is white discharge PV also. So there is a chance of overlapping lesion. The lesion could be on the cervix, on the vulva, or it could be in the vagina or coexistent lesions. So the first step to evaluate this case is a proper clinical examination. For this, you have to go for the local examination of the vulva to locate any lesion on the vulva, whether it's an ulcerative lesion, whether there is any color changes, flat or raised lesion. All this you have to locate, and the site of the lesion also. Second thing is, you have to do a perspiculum examination to see for the vaginal lesion or the cervical lesion. And the next important step is you have to take a pap smear and the HPV testing also, because just now Dr. Bharti told us that 60% of VIN2 and 3 lesions are associated with the coexistent CIN lesions. Therefore, it's very important to take a pap smear and the HPV testing sample when we do the perspiculum examination. If we locate any lesion on the vulva or the cervix, you have to go for a vulvoscopy or the colposcopy of vagina and the cervix. The additional test in this case will be the blood count, then blood sugar level, because she's a diabetic. We know that the sugar is a good culture medium to grow the vulvovaginal or candidal infections. So you have to see the sugar levels were maintained on it, after, of course, a zero status of the patient. And one more thing I would like to add, you have to go for ultrasonography of this patient to see the endometrial thickness, as at the age of 54 years also she is menstruating. So all these tests are important to evaluate and come
good
to the conclusion.
Yes, very good. So in routine tests, we have to include the STD panel also along with our routine sugar and HIV test. So thank you, Dr. Veena, for that very precise narration. So this was NICEDA examination of the patient. Here, can you see this arrow? This is a red, angry looking vagina. This is anterior vaginal wall with a cystocele, and there were patches all around the perineum or around the vulva. So I did her colposcopy. These are the colposcopy images. So my next question is to Dr. Sandeep Phadke. Can you please describe the colposcopic findings in this patient?
Yes, good evening. First of all, I would like to thank Dr. Bharti Madam for giving me the opportunity. As per these pictures, the colposcopy, it seems to be an adequate examination as whole of the cervix is being seen. This columnar junction is seen in majority of the part except some portion suggestive of a type 2 type of a transformation zone. There seems to be an acetohyte area which is seen on the upper lip involving almost 2 quadrants of the cervix with some porous mosaic in it. Yes, and the iodine uptake again was seemed to be patchy, suggestive of a squid core, like in this case would be around 6 to 7, suggestive of a high-grade squamous intraepithelial.
Yeah, so the lesion here seems to be entering into the endocervical canal also. And rightly said by Dr. Sandeep, the total score, the acido uptake is 1, margins are sharp but irregular, vessels were mosaic, lesion was occupying 2 quadrants and extending into the canal. And so the iodine uptake was patchy and the total score was 7. So the diagnosis was H cell. So Dr. Madhuri, is there any role of colposcopy in vulvar lesions? We have done a colposcopy now for cervix. Now, is there any role of colposcopy in vulvar lesions?
Yes, ma'am. Definitely, there is role of colposcopy in vulvar lesions, and it will decide whether it is a low-grade lesion or a high-grade lesion, and from where we have to take the biopsy.
Right. So, any different points you want to stress during colposcopy in these vulvar lesions? Any else than routine steps of colposcopy?
The steps of colposcopy will be the same, use of 5% acetic acid, and 1 minute we have to wait and see for the lesion, the size of the lesion,
mainly it's a timer.
Yeah,
Usually
yeah.
it is 3 to 5 minutes, not a 1 minute, because it is a thick squamous epithelium and we need to wait. So what I usually do, I do colposcopy, and then while coming out, I do the vulvoscopy. By that time, usually the 3-4 minutes have been passed and we can do it. Otherwise, if you are going to do only vulvoscopy, you have to wait for 3 to 5 minutes, and the magnification is usually sufficient up to 7 times. So these
No,
were the,
yes,
yeah.
a dense acetobite lesion with raised, you have to biopsy that lesion. And at any point of when we take a lesion biopsy from the vulva, we have to include, that is the suggestion, that is suggestion from the pathologist. We have to include the normal
Normal.
skin also when we take the biopsy, that we have to take care
Yeah,
of.
yeah. So here we can see the acetoid patches, and some warty growth also was seen at the introitus. I didn't had a toluidine blue, so I had applied iodine only, Lugol's iodine only. And so, Dr. Veena, again, can you describe what is vulvoscopy? Is it same as colposcopy, or it is something?
Vulvoscopy is a systemic examination of vulva in simple language. But recently, the new approach is proposed for vulvoscopy, where we examine the vulva in 3 different zones in a ring-like manner. And these 3 different zones are dependent on the origin, embryological origin, and also the histopathological status, that is histological pattern. So, the outer zone, it consists of the mons pubis, the labia majora, and perineum in the inferior margin. While the middle, it consists of the anterior commissure of preparium, then the labia minora, and the posterior commissure. This is the portion. While in the inner portion, when it is the clitoris, the urethral meatus, the remnants of hymen, and the opening of the Bartholin glands. So these 3 zones are examined. As these 3 zones are originated from 3 different embryological tissue origin. For example, the outermost is a keratinized. It is from ectoderm. The middle zone is from the modified mucosa of the ectoderm, and the innermost we know that it is from the non-keratinized stratified squamous epithelium from the endoderm. Because this is very important. We know that the vulvar lesion usually are the multifocal lesion. They are not only focal lesions at one point. So the thorough examination of the vulva in this vulvoscopy in a ring-like manner is very important, so that we will not miss any lesion. And that is very important.
Yeah, yes, thank you so much. So one point is we should examine the anus also when we finish our examination. And all women with HCL of vulva should be screened by cytology and HPV before evaluating the vulval lesion. 60% of women with vaginal intraepithelial neoplasia, 3 VAIN3 or VIN3, they have pre-existing or coexisting SIN lesions. And 10% of women with SIN3 have concomitant SIN lesions at other sites. And as stressed by Bhagyalakshmi madam, follow-up is a must and must. So, Dr. Sandeep, what is Collins test or toluidine blue test?
Actually, the choline test, it uses a toluidine blue dye. Now, this toluidine blue dye, it's used for vital staining. That means it will stain the cells with the increased nuclear activity, which is commonly seen in pre-malignant and malignant conditions. So, if you want to do the Collins test or the toluidine blue test, you have to use 1% of an aqueous solution, which is commercially available. Apply it thoroughly for around 1 to 2 minutes. And then you have to, like 1% of acetic acid you have to take and rinse the skin or the region which you want to examine. The principle is whenever there is an increased nuclear activity, the tissue or the cells will stained as blue, and that is said to be a positive toluidine blue test, and it will help you to guide the biopsy.
Right. So if we don't have a toluidine blue, should we skip this test, or is it a mandatory test? It must be done.
Actually, the principle of both the acetic acid as well as the toluidine blue seems to be same, but if additionally it will give you more benefit, especially in vulval and the vaginal region.
Right, right.
Actually,
So,
rate, the sensitivity of this test is less. So we cannot totally rely on this, but it can be added to our clinical diagnosis.
Yes, yes, definitely. So if you don't have it, then it doesn't matter. So my next question is, Dr. Madhuri, what are the indications for vulval biopsy?
Yeah, any the indications of vulval. First of all, after description of the vulvoscopy, after if we find any lesion, and we diagnose any lesion, then these are the indications for vulval biopsy. That is what any lesion on the vulva, that yes, any lesion we have to biopsy confirmation for the confirmation.
Right. The lesions that are raised or pigmented, then presumed benign pathology of vulva, unresponsive to office treatments, then vulvar dermatosis, where the diagnosis is in doubt or there is no response to our treatment, and any abnormal looking lesion on the vulva and very white or thick patches on the vulva, they should be biopsied. So can you narrate the this screen is not moving. Yeah. So can you tell the methods of vulval biopsy in short, Dr. Madhuri?
Yes. Actually, we have to locate the lesion as we do vulvoscopy, and there are different methods: shave biopsy, punch biopsy, or suture lip technique. In shave biopsy, we remove the top layer of the skin, and it is used like it is confined to the epidermis. Mostly, it is done by the dermatologist. Punch biopsy, we remove small lesion with the punch biopsy forceps, and when all skin layers are the thickness is included in the punch biopsy, as we do in the vaginal or cervical biopsy. And the suture lip technique, where the tissue is fragile, or it likely to when the tissue is fragile and likely to tear, then we just have to lift it up and take the biopsy. So this is suture lip technique. So in warty growth and all, we can use this technique.
Yes. So in this case, her HPV came negative. Her colposcopy showed HSIL in the cervix and LSIL in the vulva. So she was posted for endometrial biopsy. Though her sonography was normal, but she was 54 years and still menstruating regularly with menorrhagia. So I posted her for endometrial biopsy, LEEP, and vulval biopsy. So, Dr. Tanvi, can you describe the histological features in the biopsy taken from the cervix and the vulval lesions?
Yes, so the biopsy findings in the cervix showed a SIN2 lesion, that is, the abnormal cells were occupying lower two-thirds of the epithelium of the cervix, as shown in the figure. To confirm it, we did Ki67, and Ki67 also highlighted the lower two-thirds of the epithelium, and thus the diagnosis of SIN2 or HSIL was confirmed in the cervical lesion. Then in the vaginal lesion, in the vulval lesion, the atypia was limited to the lower one third, and Ki67 also highlighted the lower one third of the epithelium. So basically, it was a low grade lesion. As HPV was negative, it was a differentiated type of vulval intraepithelial neoplasia. Uh, yes, and apart from this, P16, P16 and P53 also have a role. So if P16 is diffusely positive, then it is usually a HPV associated or a usual type of WIN. And if P16 is negative, then it becomes a differentiated WIN. P53 can also be helpful to differentiate between usual type of WIN and differentiated WIN. So in differentiated, P53 will be mutant type, diffusely expressed, while it will be negative or a wild type in usual type of WIN. Yes. So here it was differentiated.
Yeah. Yeah.
So,
Can you describe what is win 1, 2, and 3 in this picture?
Yeah, so usual type of win is usually divided into win 1, win 2, and win 3, um, depending upon how much the abnormal proliferation is limited to what epithelium. So if the abnormal cell proliferation is limited to lower 1/3, then it is win 1. If it is occupying the lower 2/3, then it is win 2. And if it is full thickness, then it is win 3. And when the basement membrane is breached and the dysplastic cells go in the subepithelial tissue, it is invasive carcinoma. So this is similar to the SIN classification that we use.
Yes. So, Dr.
And
Veena?
nowadays win 1 is LCIL and win 2 and win 3 is HCIL.
Right. Yeah. So, Dr. Veena, how will you proceed with managing the case? Now we have the reports, and how will you proceed?
Yeah. This patient is having the coexistent lesion. One is in the cervix and also on the vulva also. Cervical lesion, as it is a high-grade lesion, the treatment would be the large loop excision of transformation zone along with the endocervical curettage. And as Dr. Bharti has told that the endometrial biopsy is already taken, as she is menstruating even at the age of 54 years. But now coming to the vulval lesion, she is having a low-grade lesion on the vulva, that is VIN1. So, as she's a 54-year-old lady, she has crossed the age of 50, she's a diabetic, immunocompromised state, and there is a high chance of progression of the lesion. So, definitely, this case is not for the follow. I would prefer a topical therapy in the form of application of imicomid to the affected areas of the vulval region. And that is very important because it's a low grade lesion. It will give a good response to this topical therapy. But one important thing we should keep in mind, that when you apply this, it should be applied only on the affected areas. The other areas of the vulva should be covered with the petroleum jelly or the Vaseline, because there is a high chance of the disturbance of the other lesion or destruction of the other areas of the vulva. So this is to be followed carefully. And this topical application is to be given in a escalating dose manner. That is, in a first 2 weeks once in a week, then second 2 weeks twice a week, then thrice a week, and it should be given up to 16 weeks or 4 to 5 months. And why it is given usually in a escalating manner? Because the hypersensitivity reaction, if it has to occur, you can understand in the first 2 weeks of the application. Another thing, the woman is given a good idea that there could be some reaction after application of this topical agent, that there will be some inflammation, pain, or irritation at the site of application, increased sensitivity to the sunlight. All this could happen. So the patient should be counseled before application of all these things. And one more important precaution, that it should not be applied to the broken screen or in the autoimmune disorders like lupus, or in case of rheumatoid arthritis, it is not to be applied. So the best way in this case should be the topical therapy.
Yes. So while managing these cases, we have to consider patient's age, the focality and the centricity of the lesion, and the area of involvement also. And the treatment being, in this case, being multifocal, requires treatment in several areas, as told by Dr. Veena. Some lesions, as this is a very low grade, they regress spontaneously, and treatment should be based on histological findings and not on presence of HPV infections. So we have a topical therapy, which Imikvimud just now told. Now coming to ablative therapy, I think we have time. Already it is 8:10, but we can finish this case at least. So regarding for this ablative therapy, Dr. Sandeep, can you narrate about the ablative techniques and therapy?
No first-hand experience of any ablative therapy, but still to conclude or to summarize the things, ablative therapy is especially useful whenever you have got you want to conserve the anatomy especially used when the patient is younger, can be used under local anesthesia. Here intention is to ablate 1 millimeter in depth. As in cases of an CN in cervix, we ablate around 4 to 6 millimeters. Here, the ablation which is required is around 1 millimeter when there is a hair-free epithelium and around 3 millimeters of depth in a hairy areas. Commonest ablative therapy which is used is the carbon dioxide laser vaporization.
Yes. So Dr. Madhuri, what are the indications for excisional therapy?
Yes, actually, that is what I wanted to highlight in this case. She was the lesion on the vulva, which was SCL. It was single lesion. I forgot.
No, it was multifocal and it was LCL. It was not HCL.
Yes,
HCL
yes.
was on the cervix.
Yeah, so excisional therapy, if it is a single lesion, solitary lesion, then if we can remove it completely, then the excisional therapy would be better. And in high grade lesion, of course, the excisional therapy is indicated. Preferably, we should have a 5 millimeter margin when we excise the lesion. And if you have a frozen section available at your institute, it is better if you can send also. And 4 millimeter depth in excisional therapy is required when we excise the lesion. And the benefit is that it gives us idea whether if there is any invasion. So high grade lesion has to be excised. Wide local, yes, wide
So-
local excision, yes. Yes, ma'am, go ahead.
Yes, you can. So because of short of time, I'm worried. So I'm trying to wind up. So
That's
just
what I emphasized.
how much time? Yes, Madhuri.
If you have a frozen section facility available, you can subject that lesion for the frozen section to see the margin negativity. If it is, she said that the margin is not adequate, then you have to revise the margin on the same setting. So that will be a complete treatment.
Right, right.
Therapy.
Yes. Yeah. So what about the rate of recurrence, Dr. Veena?
In these cases which are treated after VIN treatment, usually the rate of recurrence is very high, and in many of the studies noted it is as high as 9 to 50%. And in 25% of the women, the recurrence is seen even 15 years after the treatment of VIN. So the long-term follow-up is very important in these cases which are treated with the conservative ways when we treat the VIN cases. And usually the recurrence is seen in those women who are more than 50 years of age, who are immunocompromised, or there is persistent HPV 16 or 18 infection, usually HPV 16 persistent infection. Then the margins are positive even after the excisional treatment. And there is associated other inflammatory chronic condition like lichen sclerosis. And so it is very, very important, and it signifies the importance of a long-term follow-up even after the treatment of the VIN.
Yes. And in vulvectomy group, the recurrence was very less. So, Dr. Sandeep, is there any role of vaccination in these lesions?
Like HPV dependent lesions will definitely have benefit if the woman is already vaccinated with the HPV. Now, regarding the therapeutic role, there are certain studies which tells that either the adjuvant therapy along with the treatment, it will help to reduce the recurrences of the lesion.
Yes. So we don't have, but we had one lecture during the ISCCP Con at Kolhapur regarding the therapeutic vaccines, and the points were covered very nicely in that also. So as told by Dr. Bhagilakshmi Madam, Dr. Madhuri, can you tell about the follow-up in short?
Yeah, follow-up for every 6 months for 5 years, and then then annually till 20 years.
Yeah, so it should be basically a lifelong follow-up that
Yes.
must be emphasized to the patient. So do we have a time? Should we continue for the second
I think
case?
we have
We have
reached
crossed the
our
time
limit. because actually delegates also decrease in number. So we should be giving.
No, it's okay. So that's why I asked. So should we stop here?
Yeah.
Yeah, so this was actually a very good case, and it was managed by Dr. Madhuri only. It was a case of Paget's disease. Just I will show the pictures. Madhuri, in short, you can just narrate.
She's 75 years old, present. She had a symptom, known case of diabetes, had a symptoms of itching and burning at vulva. And there was a lesion, erythematous plaque-like lesion occupying whole of the right labia majora and going up to clitoris. And on biopsy, it was suggestive of Paget's disease. So this, how the pathologist, Dr. Tanvi, will add in it that it is the because it is the presence of mucins, intraepithelial mucin producing neoplastic cells, that is diagnostic histopathological diagnosis. And there are different, there are mammary Paget's disease we know, but extra mammary Paget's disease, this vulvar Paget's disease is a rare condition, but it mimics vulvar carcinoma. So we have to differentiate, and pathologists add in our diagnosis. And the main treatment is wide local excision with adequate margin. And there are different classifications. It can Paget's disease of vulva, type 1 and type 2. It is primary cutaneous, it is type 1, which is again divided into non-invasive and invasive disease, and vulvar adenocarcinoma. So if it is non-invasive Paget's disease of the vulva, then the prognosis is good, and the treatment, wide local excision with good margin negativity, it is enough. But if it is invasive Paget's disease, we have to manage these patients as vulvar carcinoma with inguinofemoral lymph node dissection and all, if it is required. So as it mimics vulvar carcinoma, we should know about this entity also. And this patient was having large lesion. So after wide local excision, we had to take the gluteal flap for the reconstruction, because this, after excision of the lesion, the breakdown of the flap and all these are the complications associated. But she recovered. It was non-invasive disease, so surgery was sufficient for this patient.
Okay, so thank you so much, Madhuri. And I'm sorry I will have to wind up because of shortage of time. So I thank everyone for participating in the this panel discussion. And I thank again to Aruna Madam for giving us the opportunity. And I think everybody will start looking for the vulva and vagina, and not only the cervix. So that is mainly the take-home message, because many times we forget, we just give ointments and creams and we send the patient. But there are many lesions to look for in the vulva and vagina also. So thank you so much. Thank you all the participants. Thank you Bhagya Madam, Leela Madam, Gitanjali Ma'am, and Smita Joshi Ma'am also.
Thank you, ma'am.
Thank you Bharti, so much.
Thank you.
Thank you, ma'am.
Thank you.
Thank you everyone for joining today, and Dr. Bharti has conducted a wonderful seminar today. And with this, I would like to again reiterate that we are going to start on a vulvovaginal module, that is inside from September. Enrollment will start very soon. All the information will be there on the website, and we have a very good faculty, and I think definitely you are going to gain from that course as you are gaining from the colposcopy course.
So we are looking for that, madam.
Yeah, thank you. With the support of you all, we are definitely going to gain knowledge and build up the good reproductive health among all females.
Yes, thank you. Thank you so much.
Thank you.
Thank you. See you soon. Next month, 7th.
Thank you.
Thank you, Dr. Bhaglakshmi.
Thank you.